Vishal is the next speaker. Yeah, thank you. Right. And he's talking of, this should be interesting. Tirzepatide versus semaglutide, where do we stand?
I kept the star talk for a little later because I thought a lot of people would have disappeared by now, and they have, despite the star talk. So I think this is going to be the world's first unpublished data, which we're going to publish very soon. Head on head, semaglutide versus tirzepatide. I'm going to. Uh, I don't want to run over the time, so I'm going to take this a little quickly. So, what would your first choice of weight losing drugs in a patient with diabetes be? So, out of the 8 options that is there, can I have a raise of hands for option one? Okay. Raise of hands for option two? Three. So, I see the number of people with three are more than one, and two, there were few takers. Option four? Okay, so I hope you know what is optimal dose of metformin. You said metformin, but what is the optimal dose for which Professor Riley got the Nobel Prize? 3000 milligrams. 3000 for which Professor O'Reilly got the Nobel Prize. So I don't think Indians tolerate this. Maybe Sardars, Punjabis, and Parsis. Anybody other than that is not going to be able to reach. So you take 1000, right? 1000, no? Okay, SGLT2 inhibitors by themselves. Okay, so combination of SGLT2 with a GLP, right? Right? And none of the above. So a lot of people would prefer exercise, but again, we know the dismal story there. So let's outline the talk on their effects on the A1C, weight, metabolic parameters, cardiovascular, renal, hepatic. And I think I'll just impress on one thing on the retina. I think Professor Sethi has cleared that, but I'll re-emphasize one thing in the retina. Effects on the brain and the nerves, which a lot of people don't really talk about. Inflammation. I've mentioned a lot of this already in my previous talks. Now, you all remember when the NICE committee sat in 2023, they all voted saying that semaglutide should be stopped in 6 months if the patients do not lose more than 5% of their weight. There were a lot of people in that committee who got up and they said, listen, semaglutide still goes and does a lot. Why are you making it weight dependent? And to justify, so they put semaglutide and they valued it to the weighing scale. And the next slide justifies exactly why those group of people who stood up were right. If you look at what is marked in green, so if you look at 3-point MACE, 4-point MACE, 5-point MACE, you look at renal outcomes, EGFR, slope reductions, renal death, cardiovascular death reductions. They are weight independent by as much as 85 to 90%. The only thing that becomes dependent is new onset albuminuria and MACE, but that too 70%. So which means 90% of kidney, renal, and hepatic outcomes are going to be weight independent. And in terms of new onset microalbuminuria, still 70% is weight independent. That's the value of these drugs. Up till now, what we've seen from the data, and I think it's a very nascent drug. I'm not comparing two drugs. I think they're apples and oranges, but still. And I don't take one away from the other. But as of now, the data we have is tirzepatide, all their benefits are weight dependent, right? And that becomes a little of an issue from the first talk I gave in the morning, where most of our Indians are sarcopenic, diabetic, and obese from the visceral fat point of view. Now, whatever you compare, whichever dose of semaglutide with tirzepatide, there is no head-to-head, but every single dose equivalent. So what have you all been taught? 5 milligrams of tirzepatide is 1 milligram sema, 10 milligrams is a 2.4 sema. and 15 milligrams did not have a worthy sparring partner till they came up with the 7.2 milligrams. And I'm going to comment on the 15 and on the 7.2 and most of the other data that you already know. Now, please focus on the red. That's the comparison between oranges and oranges. That's the 7.2 sema versus the 15 tirzepatide. If you look at the weight in kilograms and percentages in diabetes, they are very well matched. You look at the data in diabetics, maybe not the non-diabetics, but in diabetics, they are again extremely well matched, up to 14%. If you look at other obesity markers like the waist circumference, you look at the total fat loss, you look at the visceral fat loss, again the 7.2 milligrams and the 15 milligrams are equally matched. Don't forget that the 7.2 milligrams dropped 11.7 centimeters on their waist over and above the 2.4 milligram semaglutide. So we've now got a worthy sparring partner to 15 milligrams of tirzepatide. I told you a little earlier that the triglyceride lowering is up to 40% with both the 7.2 and the 15 milligrams. Let's look at the cardiovascular markers. Now, I think the most striking here is stroke and stroke death reduction. So if you look at stroke death reduction, it is as much as 39% for non-fatal stroke and as much as 25% from death from stroke. We've talked about all the other 3-point, 4-point, 5-point MACE. Now, this is the STEER data. Now, I view this with a little caution because this was funded by Novo Nordisk. They looked at the Komodo database, which was a retrospective database. But what they found was the 23 and the 29% reduction in 3 and 4-point and 5-point MACE was predominantly from 3 factors. It was from stroke, 51% reduction. It was from myocardial infarction and heart failure, between 62 and 66% reduction. Let's see if this translates into our data. If you look at the renal parameters, you see the renal, it's not fair because tirzepatide really doesn't have renal data. We know from the FLOW trial and the RESOLVE-D, which I'll show you a little later, which includes biopsy and data on the perinephric fat and the renal sinus fat, that we know from the FLOW trial that there is an average 20 to 29% reduction in all renal mediated endpoints. Now, this was the remodel trial. I think Novo Nordisk got it really smart. They did MRI flow studies. They looked at renal vein and artery velocities. They looked at the perirenal sinus. They looked at the perinephric fat and they looked at the renal sinus fat. And what they did was, this is not just MRI. These are biopsies taken. They found a 25% reduction in the epicardial fat and a 13% reduction in the renal sinus fat. If you remember, I told you that the pathophysiology of diabetic nephropathy starts with the perinephric fat and the renal sinus fat takes it over once it starts slipping into the moderate and the severe phases. If you look at the liver, you see the 2 red lines, the semaglutide 7.2 and the 15 milligram tirzepatide, that improves liver fat through MRI as much as 60 and 65% that we've seen so far. We've now got a single outstanding drug that is in a position to remove. So if you all remember the rule of thumb, right? You drop 5%, liver fat comes down. You drop 7.5%, inflammation comes down. And you drop more than 10%, the liver fibrosis starts reversing. Which is why when you see lifestyle studies, you get amazing results as long as people can hold that down. But you see that the weight comes back in 9 to 37 months in all those people who do lifestyle. Now, this is the data on dementia, on peripheral vascular nerves, on the autonomic nerves, and peripheral vascular disease. You look at the absolute risk reductions. So for every 100 people that you treat, you are going to save between half and 2 people for all the conditions I've mentioned on the left. What I find really interesting, the sudden cardiac death. Remember, if you remember the COVID select study. So when they did the select study, it so happened that it happened during COVID. So the people on semaglutide, what they found was the people on semaglutide had a 34% reduction in sudden death and cardiovascular death. I think one of the attributes is we know heart rate variability is a serious autonomic issue. We know these people have sudden death in the night, whether it's ventricular arrhythmias or arrhythmia related. And I told you, I'd remind you, semaglutide versus albiglutide, there was a 50%, 57% reduction in arrhythmias. This is the eye disease data. And I want you to see the blindness data, and I want you to see the retinopathy data. So despite an initial mild worsening, there is a 15 to 20% improvement in diabetic retinopathy in the long run. Okay? So when an eye specialist writes to you saying that, listen, I don't want semaglutide, you have to view the patient in toto. We have used semaglutide consistently in people with retinopathy, and we get letters back saying, thank you, because now all our anti-VEGF treatments are working. What we couldn't do with 4 and 5 injections is happening with 1 and 2. So look at the larger picture, and I always get the patients on board. I tell them, listen, this is the data, but I strongly suggest that it's going to work. And please involve your patients in the decisions that may be remotely controversial. This is the inflammatory data I told you. You all know semaglutide versus tirzepatide. You know that tirzepatide can bring the CRP down and the IL-6 down by 40 to 62%. And again, 7.2 milligrams matched for the 15 milligrams. This is the translation of MACE reduction once the inflammatory markers come down. And you look at the orange marks, and the orange marks are similar for the two tirzepatide and the semaglutide data. So what is your conclusion? Now I ask you the same question to all the people who chose tirzepatide. Would you consider semaglutide? Would you all consider semaglutide? I told you, look at me. 7.2 semaglutide 15 days, 25 tirzepatide 15 days. I really found no difference in either of the two at those doses. Now, I'm going to show you Indian data. That's what happens in Indians. So this was the study. We are going to expand this and publish this. Obviously, it's going to be the first data in the world. This was a very well matched. So we paid attention to the statistics a lot. We matched them through propensity scoring. We made sure every marker that could affect weight, the kidneys and the heart were well matched. We matched the statins, the ezetimibe, we matched the ARNIs, we matched the ARNIs, we matched the ARBs, the calcium channel blockers, we matched the weight, we matched the blood pressures, we matched everything. So we looked, I thought the most difficult marker would be the NT-proBNP for any drug to bring down. So we used that as a primary endpoint. We did the ANCOVA analysis at the end, and we corrected each individual marker with the Bonferrome's correction. So you don't get this higher than the Bonferrome's correction and the propensity matching. This was the baseline. If you look at right from weight to the metabolic markers, the cholesterols, the LDLs, the systolic blood pressures, you look at every single marker, they were matched. I particularly put this slide out because when semaglutide came out first, we were very slow. Because all the nausea, all the vomiting, we learnt a lot from semaglutide. So if you look at the way we escalated from 0 to 3 months to 6 months, we reached an average dose of 1 milligram with semaglutide over 6 months. But we learned better with tirzepatide. So we reached an average of 9 milligrams at 3 months, and we got an average of 13.9 milligrams at 6 months. The The slope for semaglutide was like this, and the slope for tirzepatide was like this and like this, telling you that we titrated much faster with tirzepatide. And again, it was learning from the semaglutide. These were the classes of drugs that we matched completely, telling you that the study was fantastic. If you look at the individual HbA1c reductions, intra-group we got significant reductions in both. They were equally well matched, even though the numbers were numerically in favor of semaglutide, they were extremely well matched. This was the weight, the BMI, systolic pressure, and the diastolic pressure at all points, 3 months and 6 months. There was no comparison between the two drugs. We looked at the metabolic markers, the triglycerides, we looked at the cholesterol remnants, we looked at everything. Every single drug and every single metabolic component was well matched. We looked at the kidney markers, everything was well matched. Now I highlighted only 4 of the numbers because the others had some outliers, and the standard deviations were too far and they were wide. So if you look at the weight, the average weight was about 4% in both, the BMI the same, the EGFR exactly the same, and the BNP came down by 65% in both the groups, exactly the same. So whatever you've been taught till now, 1 milligram equals 5, 2.4 equals 10, and 7.2 equals 15. There was no head-to-head till now, and there was no Indian data till now. So coming down to your point, are these effects of sema weight independent? There's a clear indication. Obviously, we got weight reduction in both. I'm taking nothing away from tirzepatide. It is an outstanding drug. I'm just saying, remove your inhibitions. You need to view both of them separately. They are apples and oranges. Your choice. You're not going to lose with either. With tirzepatide, you need to make sure that you lose weight, and a lot of data will come from their side in the next 5 years. On that note, I ask all of you the question again. Would you use how many would use option 1? Come on, one more needs to raise hand here. Thank you. Thank you. And tirzepatide. Okay, because it basically comes down to either or. And I'm like, it comes down to choice now. Nothing else. We conclude saying that they are both outstanding drugs. They're both winners, and you really can't choose between them. Thank you so much.
Thank you, Vishal, for an excellent presentation.